Wondering what options you have when medications stop working on your difficult epilepsy patient? That's next on Sutter Doc Talk.
Welcome to Sutter Doc Talk, a Sutter Health Network podcast hosted by physicians for physicians. Each episode features candid conversations with clinical insights and best practices. Now, today's topic.
Hey there, my name is Dr. Sam Ciricello. I'm the Medical Director of Adult and Pediatric Neurosurgery here at Sutter Medical Center in Sacramento. I'm also the Director of Neurosurgery for the Sutter Health Valley area. Today we're going to talk about the role that the surgeon may play in dealing with refractory epilepsy. Epilepsy is a very common problem, affecting about 1% of the world's population. About a third of the time, these patients are not going to be adequately managed by medications alone, creating a very huge potential health risk and the potential for death in about 1 in every 1,000 patients that suffers from epilepsy. Now, you're not going to call the surgeon directly to help you with these patients, but hopefully by the end of this talk, you'll understand how important it is that you get your seizure patients to a board-certified epileptologist. Surgery does play a very valuable role here in both the treatment and the evaluation process for epilepsy patients. And one should consider using a surgical approach when patients have failed 2 or more medications. Now, appropriate treatment really involves a team approach. And ideally, that team should consist of the community treating neurologist, a board-certified epileptologist, a surgeon that has some special expertise in epilepsy surgery, neuroradiologists, and then a team of other experts, including technicians, social workers, and even the equipment that we use and implant in patients that have these disorders. Treatment begins with what's called phase 2 monitoring. Phase 2 monitoring involves putting a patient in the hospital under video surveillance with electrodes placed either on the surface of the brain or deep inside the gray matter of the brain. Historically, this has been done through tiny windows called burr holes or through larger cranial flaps, sometimes involving even as much as half of the cranium being removed so that surface electrodes can be placed on the gray matter of the brain and electrical recordings can be carried out. The patient then stays in the hospital for as long as a week or 2, being closely monitored for epileptic spells. And once enough data has been acquired, the patient then returns to the operating room for the grids or strips to be removed. That data is then analyzed, and the team then comes up with an approach that may surgically help that particular individual. An example might be an array of 60 or more electrodes placed on the surface of the brain with numbers or letters placed on them that allow the epileptologist to see where the seizure-like activity is coming from. And it also serves another very important purpose for the surgeon, and that is each of these numbers or letters also allows the epileptologist to stimulate parts of the brain, giving us information about very critical functions like speech, language, memory, or vision. That becomes incredibly important when we're looking at seizure areas that are very close to eloquent areas like speech and language, which may make it impossible to remove the seizure without removing that particular function for a given individual. Now, more recently, many centers across the world have gone to a newer technique called stereo EEG implantation. This newer technology requires use of a very sophisticated and very expensive robot that allows us to place stereotactic depth electrodes deep inside the gray matter. This allows us to map not only the surface like we used to be able to do, but also to gain access to information from the deeper gray zones. It doesn't require any hair to be shaved, which has huge importance to the families and the patients, and doesn't leave the patient with any large scar, which the old-fashioned approaches might do. An example would show a number of electrodes, sometimes as many as 20, inserted deeply through the brain so that both sides can be recorded, again, for a period of a week or more, and that same information then proceeds to a multidisciplinary panel for discussion about what type of surgery would best benefit that particular patient. So once the data has been analyzed, what do we do from the surgical perspective next? Well, one of the things we might do is implant what's called a vagus nerve stimulator. A vagus nerve stimulator is a form of treatment that adds to the medications that the patient's already receiving. It isn't a cure. It simply helps to control the patient's epilepsy. Interestingly, families also tell us that in addition to the seizures being better, oftentimes their difficult mood swings and difficult self-mutilating behavior may actually improve following implantation of a VNS as well. Because it's not a cure and because it's dependent on electricity, these devices need to be periodically monitored, adjusted, and eventually the battery will fail and the patient will have to come back to surgery to have the generator replaced. Another form of treatment that might be decided upon is something called a corpus callosotomy. Some patients have very troublesome immediate drop attacks that occur that can make them very prone to head injury and other soft tissue injury from rapid falls. In a corpus callosotomy, what the surgeon does is sever the connections between the right and left hemispheres of the brain, essentially preventing the highway that allows seizures to rapidly spread from one zone of the brain to another. If that data has shown that patients have a very focused area of epilepsy in the brain, what do we do next? Oftentimes that prompts us to want to ablate or remove that part of the brain. And historically that has meant physically going in and extracting that particular zone from the brain tissue. That involves typically a large hole to be able to do that work, a large scar, a recovery time of 4 or 5 days in the hospital, and a constant reminder on the head of that patient what they had to go through to cure their epilepsy. In some patients, that surgery might even require removal of half of the cranium and a disconnection or removal of half of the brain, something that's called a functional or anatomical hemispherectomy. Over the last decade, surgeons have come up with a more novel approach, one that is now really become the standard of care. And that's a treatment option called laser interstitial thermal therapy, or what we more colloquially call laser ablation. We use an opening no bigger than the size of an ink cartridge in a Bic pen, and through that small opening place a laser beam probe so that the zone of epileptogenic activity can be thermally ablated under the guidance of an MRI machine. This obviously requires coordinated efforts between operating room staff, imaging center, neuroradiologists, anesthesiologists. With laser ablation, here's how it works. Probe gets inserted, the laser beam gets deeply situated deep into the epileptogenic zone, and then the laser beam is turned on and the tissue is congealed and the seizures evaporate. Well, what happens if you don't have a discrete, specific focus of seizures? And many patients don't. There's a new technology called responsive neurostimulation that's available. This type of treatment is useful for patients that have 2 or sometimes even more than 2 zones of epileptic activity. Like the VNS, it isn't curative, so it's used to stimulate activity within the brain when the brain begins to have a seizure. It constantly surveys the brain for epileptic activity. When it begins to sense it, it will give the patient's brain a jolt or a shock, if you will, to try to pull them out of that seizure activity. Unlike the VNS, the RNS technology requires a hole to be drilled in the skull and probes to be placed on or in the brain tissue. So it's a little more invasive than the VNS or the laser ablation, but still is very successful for treating patients with multifocal epilepsy. Like the VNS, generators don't last forever, and eventually battery needs to be replaced. So what did we talk about today? A multidisciplinary team is really critical to the excellent outcomes and safe treatment of these difficult patients, and that oftentimes will include the neurosurgeon as well. Those clinicians have to have an excellent working relationship with one another and with the family. We can oftentimes cure these patients. That's excellent because we're dealing with a group of patients that otherwise medically are uncurable, but it requires that the families work with us in order to undergo a very rigorous pre-assessment process. So if you have a patient on 2 or more medications and they're still having seizures, consider picking up the phone and calling the Sutter Specialty Network. Their trained staff know how to reach the appropriate people for thorough evaluation and be sure that your patient gets the care that he or she needs. Thanks for listening.
Sutter Doc Talk is a production of the Sutter Health Marketing Department and is affiliated with the Sutter Health Network. Do you want more Doc Talk? Find all of our episodes online at sutterhealth.org/doctalk. That's DOCTALK. Talk to you next time.